I've been practicing urology since 1982 in Lake County, Florida. I went into urology because when I took a urology rotation in medical school, I thought it was very interesting. Plus, the patient demographics for urology were the most fun for me to deal with. The older guys, they know a lot of jokes, they're fun to take care of, and I naturally went in that direction. Then I saw my first TURP performed, and I thought that was really cool. So it's a combination of all those things that got me into urology. For years, when I started my practice, the only treatment for an enlarged prostate was a transurethral resection of the prostate, or TURP. I did over 3,000 TURPs in my career. Then when Flomax came out, Flomax wasn't as good as a TURP, but it was good enough not to have a TURP. So I started prescribing a lot of Flomax to my patients. But their prostates would continue to grow, the Flomax would be less effective. Next thing I knew, I had patients on 2 Flomax a day, then I had them on 2 Flomax and a Proscar, and some of them continued to grow. So I called a colleague friend of mine in Orlando and asked him what he recommended. He asked me if I had ever considered doing a transurethral needle ablation of the prostate, now known as Prostiva. I had a patient that I thought was an ideal candidate. I sent him down to Orlando, he did the procedure on that patient, and the patient did remarkably well. So I decided that my nurse and I need to go down and watch one being done to see if we were able to do this. As soon as I saw the first procedure performed, I knew I could do it very easily with my experience of TURP. So that's how I got introduced to Prostiva. Any urologist that's done a number of TURPs will understand how to do the Prostiva very quickly. We all know how to resect tissue, what may be offending the water channel with occlusive tissue of the prostate, and how to resect it. In my experience, those areas that could be resected are easy to take care of with the Prostiva.
Prostiva RF therapy is a safe, effective in-office treatment that provides long-term relief from BPH symptoms and urinary obstruction. Proper patient selection is a critical first step in successfully applying the treatment. Prostiva RF therapy is appropriate for men experiencing moderate to severe BPH symptoms, especially patients who do not want to take daily medications for the rest of their lives. The physician should discuss treatment options with the patient. If the patient expresses interest in Prostiva RF therapy, a thorough patient evaluation is needed to make the final treatment recommendation. It is critical that the patient is thoroughly educated on the procedure, including how to prepare, what will happen the day of the procedure, and setting realistic expectations on what will happen after the procedure has been completed.
In my experience, I have found the more a patient knows, the better the patient is going to do. Doing 3,000 TURPs and 1,000 Prostivas has given me an understanding on what the patient needs to know. I draw a lot of pictures on the back of the chart to explain to the patient what's going on. I'll draw a picture of the bladder, the water channel, the prostate, the relationship of the prostate to the water channel and the bladder, and then what happens as the prostate enlarges. Then we'll talk about how Flomax works. We'll talk about how the Prostiva is performed and what to expect afterwards. But I draw a lot of pictures to try to get them the best understanding they can have. As far as treating the symptoms of their enlarged prostate, patients do have a choice to stay on medications, but we discuss the side effects in detail. All of us have experienced patients that have postural hypotension from Flomax, patients that have retrograde ejaculation, or patients that just don't feel good when they're taking it. And then there are the side effects of medication like Proscar. The longer you're on the medication, the more it's going to affect your erections. So getting patients off these medications is a good thing. Once we've determined that a patient may want to proceed with Prostiva, then I will try to give them more educational materials. I'll tell them which websites to go to. I'll also give them a DVD that goes into more detail about the Prostiva procedure. I find that's very helpful for a patient to be able to watch this at home.
A typical pre-treatment assessment may include an International Prostate Symptom Score, also known as American Urological Association Symptom Score. In addition, the physician may also choose to calculate a quality of life score. The physician should do a thorough medical history, document all medications, and perform a physical exam on the patient, including a digital rectal exam. Additional tests may include a urinalysis, urine culture, and a blood analysis, specifically a serum PSA, BUN, creatinine, and glucose. The physician may want to consider INR if the patient is anticoagulated. A bladder ultrasound should also be performed to test for post-void residual. Certain patients will have a urodynamic study with or without a uroflowmetry. All patients found to be candidates will need to have flexible cystoscopy prior to being scheduled to rule out stricture. It is also important to evaluate the patient to identify conditions that can mimic lower urinary tract symptoms secondary to benign prostatic hyperplasia, BPH, such as UTI, Parkinson's disease, bladder, or prostate cancer.
When a new patient comes to my practice, I personally interview them and examine them. We'll discuss all the symptoms associated with bladder outlet obstruction, and then at the end of the interview, I will examine them, do a thorough physical exam, ending with the prostate exam. When I do the prostate exam, I try to note the size of the prostate, the consistency, whether it's symmetrical or asymmetrical. I'll draw a PSA on every patient that comes in my office that has a prostate that's over 40 years old. I think my first job is to make sure there's nothing surprising within the prostate, so I really want to make sure the patient doesn't have prostate cancer. If the PSA is elevated or the prostate exam is abnormal, then I will schedule them for a transrectal ultrasound of the prostate with numerous biopsies. However, if the PSA is normal and the exam is normal, then I'll proceed with evaluation for bladder outlet obstruction. Primary care physicians treat a lot of BPH and bladder outlet obstruction without really knowing what they're treating. They may be using Flomax when they need Ditropan. They may use Proscar when they should be using Flomax. They really don't have the tools to evaluate a patient completely. I think that's what separates us as urologists from the primary care doctors. We have the ability to know everything there is to know about the prostate and the bladder function. So generally, I will order a patient to have urodynamics as the first step. When I do a cystoscopy, I want to note how occlusive the lateral lobes are, the presence or absence of a median lobe, and then once into the bladder, I want to make sure the mucosa of the bladder is normal, and then I want to check for the degree of trabeculation to try to determine how much damage may have been previously incurred by the bladder.
It is important to understand the contraindications for the procedure when determining the appropriate treatment choice for a patient. Prostiva RF therapy is a non-surgical procedure indicated for the treatment for symptoms due to urinary outflow obstruction secondary to benign prostatic hyperplasia, BPH, in men over the age of 50 with prostate sizes between 20 and 50 grams. Prostiva treats the median lobe and lateral lobe, as well as asymmetrical prostates, with the exception where the median lobe protrudes into the bladder and can collapse over the bladder neck. Prostiva is not indicated for patients with active urinary tract infections, or a neurogenic, decompensated, or atonic bladder. It is recommended that patients with suspect bladder function should undergo a urodynamic evaluation to rule out atonic, decompensated, or neurogenic bladder syndrome. In addition, Prostiva is not indicated for patients with urethral strictures or muscle spasms that prevent insertion of the handpiece sheath, or those with bleeding disorders, or taking anticoagulation medication, unless antiplatelet medication has been discontinued for at least 10 days. Prostiva is not indicated for ASA Class Group 5 patients, or patients with clinical or histological evidence of prostatic cancer or bladder cancer, a prostate gland which is less than 34 millimeters or greater than 80 millimeters in transverse diameter, or patients with the presence of any prosthetic device in the region that may interfere with the procedure. Prostiva should not be considered for patients whose prostate has been previously treated with non-pharmacological therapies such as TUMT, laser, or TURP, or those with the presence of a cardiac pacemaker, implantable defibrillator, or malleable penile implants. Finally, patients with any components of an implantable neurostimulation system should not be treated because the energy from the Prostiva RF system may be transferred through the implanted system and may damage the patient's tissue in the area of the implanted system components. This applies whether the neurostimulation system is off or on. In addition, it is possible that the neurostimulation system components could also be damaged. It is also important to understand the key precautions to ensure the safety of the patient and the effectiveness of Prostiva RF therapy. This treatment has not been established in patients with previous rectal surgery other than hemorrhoidectomy, previous radical pelvic surgery or pelvic irradiation, or with a PSA value greater than 10 nanograms per milliliter. If the patient's PSA value is between 4 to 10 nanograms per milliliter, the patient should have a negative core biopsy. Prostiva is also cautioned for patients taking medications that may affect the prostate and bladder, such as 5-alpha reductase inhibitors, anti-androgens, or gonadotropin-releasing hormonal medications within 2 months of the treatment. Finally, the procedure is cautioned for patients with an interest in the preservation of future fertility. Physicians should refer to the instructions for use for a complete list of indications, contraindications, and precautions. All of these considerations will help determine if the patient is an ideal candidate for Prostiva RF therapy. The instructions for use are included in each procedure kit or can be accessed on the Urologix website at www.urologix.com. Using cystoscopy, urologists must establish that the prostatic urethra is measured accurately from the verumontanum to the bladder neck. To determine needle deployment, a measurement is also taken at the largest transverse diameter of the prostate at the level of the urethra in the axial orientation. The handpiece has 6 preset lengths ranging from 12 mm to 22 mm. The needle shields automatically retract to protect the urethra. To determine the needle length based on the transverse measurement of the prostate, divide the length by 2 and then subtract 6 mm. This table shows guidelines for determining the number of treatment planes based on the distance from the bladder neck to the verumontanum. The table is also printed in the System User Guide. A treatment plane is the delivery of energy to the right and left lobes at the same level. Ideally, a minimum of 2 planes should be treated. That is, if the distance from the needle placement to the bladder neck and from the needle placement to the verumontanum remains 0.75 to 1.0 centimeters. In general, for each additional centimeter in length, add an additional treatment plane. The determination of the number of treatment planes is in the clinician's sole medical judgment. Treatment regions of the prostate median lobe may be described as upper, middle, and lower. If the median lobe is unusually long, add additional sites more distal to the bladder. Typically, the number of lesions is based on the size of the median lobe. Once it has been determined that the patient is a good candidate for Prostiva RF therapy, it is important to establish realistic treatment expectations. The patient needs to understand that while results are not immediate, most men can expect to see progressive improvement of urinary symptoms for 8 to 10 weeks following the treatment. Urologix provides patient education tools that may be beneficial in educating the patient about BPH and the Prostiva procedure, including a DVD which can be viewed in the physician's office or sent home with the patient for independent review. Physicians most commonly prescribe oral medications, including anti-anxiety medications such as Valium, preemptive analgesics, and anticholinergic or antispasmodic drugs. Typically, oral analgesic or anti-anxiety medications are given to the patients about an hour before the procedure. There is no one right way to manage comfort control. It's up to each practitioner. Some practitioners use a combination of oral and topical analgesic along with a prostatic block for comfort control. Types of prostatic blocks include a periprostatic block, an expanded regional block, and a transurethral block. The exact mix and dosage of medication is the prerogative of the treating physician. Clinicians normally utilize lidocaine or marcaine. Experienced urologists highly recommend utilizing a prostate block with a Prostiva procedure to minimize patient discomfort. The patient may experience a significant amount of pain if a prostate block is not administered. Patient perception of unusual pain and/or acute changes in pain is an important safety check. Therefore, it is important that the patient not be over-sedated.
I think that most people will anesthetize around the urethra, between the prostate and the rectum, and between the seminal vesicle and the prostate. But I think that for some reason we get a better block when we go up around by the bladder neck. So if you look at the pictures carefully, you'll see the typical Mount Blanc or White Mountain picture between the seminal vesicle and bladder. And we actually go above that, so it's between the prostate and the bladder. And there.
The physician introduces the needle, and it will come through at Mount Blanc. The physician may inject a small amount of the lidocaine, then pull back and run it right underneath the prostate. The physician may then move to the urethra and again inject a small amount of lidocaine. The physician should now be able to see the Mount Blanc area and may insert the needle through the top of this area and inject the majority of the lidocaine into the patient. This procedure demonstrates one possible prostate block. There are several different types of blocks which can be utilized, including a periprostatic block, an expanded regional block, or a transurethral block. These procedures are recommended by experienced urologists, and selection of the appropriate pain management protocol should be based on the clinician's individual medical judgment. Prostiva RF therapy can be performed in the same room used for standard urology procedures. It is important to set up the treatment room appropriately. The room should have adequate space for the generator, treatment table, ultrasound unit, and working space for the staff. The Urologix field representative can assist in proper room setup during initial training. Primary components of the Prostiva RF therapy system include the radio frequency generator, the grounding pad, the telescope, and the disposable handpiece kit, which contains the handpiece, tubing system, and return electrode. The generator is a portable, line-powered, dual-channel generator capable of producing up to 50 watts per channel. The generator produces RF energy at 473 kilohertz. The handpiece, including the RF cable, is packaged as a complete sterile assembly, which includes 2 insulating needles. The disposable handpiece kit is a sterile, single-use medical device. After it is used, it should be disposed of according to local environmental requirements. The telescope is reusable, but must be sterilized according to device procedures prior to each procedure. The scope allows the physician to view anatomical landmarks and the needle deployment sites directly. There are either 0-degree or 15-degree telescopic angles available. To prepare the scope, the clinician should remove it from the padded box and find the correct light source adapter. Once it has been identified, leave the adapter on the scope, sterilize it according to the device procedures, and then rinse the scope in sterile water and place it onto a sterile field using a non-fenestrated drape. The tubing system connects to the handpiece. Tubing is connected to an irrigation source, which supplies cooling fluid during the procedure. On the handpiece, there is a telescope slot assembly that secures the telescope in position. The assembly also moves, so it can be positioned and adjusted for better viewing. The handpiece is connected to the RF generator when the physician is ready to start the procedure. The RF generator is lightweight and portable. Its design and electronic system give the clinician a complete, safe, and effective procedure. The generator should be placed on a steady table. The rear panel should not be blocked to allow for airflow. The latch button opens the display screen. The power cable connector and power switch are located at the back of the device. The return electrode cable connects to the RF generator. After the unit is turned on, a startup display screen appears. There are several language options to choose from, and adjustments can be made to the volume tones. There are a number of message codes that can be displayed, as well as several safety, warning, and cautionary messages. The Prostiva System User Guide contains comprehensive information about error management and can assist in correcting many issues. In the event consultation with an expert is needed, Urologix Technical Support Department is available on a 24-hour basis at 1-888-229-0772. Prior to the treatment, it is important to check the patient's vital signs. They should also be given their pre-treatment medications. The role of the nurse is extremely critical to the success of the Prostiva RF therapy procedure. It is the nurse's responsibility to keep the patient informed throughout the entire process. Immediately prior to initiating the treatment is a good time to reiterate to the patient approximately how long the procedure will take, what will happen during the procedure, and the level of discomfort that is considered normal. Make sure the Prostiva RF therapy screen is displayed and then press the Therapy button. Confirm that the System Ready message appears on the screen. At the start of the procedure, a nurse will prep the area and attach the grounding pad, also known as the return electrode, to the patient's lower back. The return electrode has a self-adhesive surface that secures it to the patient's skin. The return electrode provides a relatively large electrode area. This helps to reduce the density of the return current flow from the handpiece to the patient's skin. The return electrode also has a split electrode design, which is required for the radio frequency generator's neutral electrode monitoring, or NEM circuit. The NEM circuit monitors the impedance between the electrode halves. This provides a measure of how secure the electrode is attached to the patient's skin. The return electrode's design and monitoring help to reduce the risk of possible patient injury. After the electrode is attached, the nurse will drape and catheterize the patient. The clinician must connect the telescope to the handpiece. It is best to hold it down distal on the telescope so it doesn't bend as it is pushed through. If difficulties with insertion are experienced, add water or lubrication to the shaft of the scope. Before beginning the procedure, confirm that it is locked into position. Assemble all pieces and connect the handpiece to the machine. Connect the light source and the water input and the camera. After the water is connected, run a small amount through to prime the tubing until there are no air bubbles in the tubing system. The nurse will drain the patient's bladder using a straight catheter. The nurse or urologist may then instill liquid lidocaine mixture into the bladder for initial topical anesthesia. That anesthesia is injected as the catheter is removed from the urethra, and then a urethral clamp will be placed for approximately 15 minutes to allow for that medication to have its effect. After the anesthesia has taken its effect, the clinician is ready to determine the number of lesions required for the treatment. The initial step is to advance the scope into the bladder. The physician should try to obtain an assessment of the prostatic urethral length and the anatomy of the median lobe, the degree of the lateral lobe encroachment. Sliding the scope in and out will adjust the visual view. Coat the tip of the handpiece with a generous amount of water-soluble, lubricating or anesthetizing gel. Carefully insert the handpiece into the urethra through the meatus. After establishing the proper needle length, set the handpiece needle length selector dial to the appropriate value. It is important to note that the needle length selection dial on the handpiece is designed to turn counterclockwise from 12 up through increasing lengths to 22, or alternatively clockwise from 22 down through the decreasing lengths to 12 to set the appropriate needle length. Forcing the dial directly from 12 to 22 or vice versa may damage the dial. As a safety measure, deploy and retract the needles to test the mechanism before inserting them into the patient. Adjust the handpiece telescope to locate the bladder neck and the verumontanum. Use the predetermined measurement to position the handpiece tip 0.75 to 1.0 centimeter distal from the bladder neck. As a precaution, note any interference in the scope field view of the urethra during the procedure. Position the needles at the deployment site by rotating the handpiece sheath completely to the appropriate lobe. Reposition the telescope to view and locate the site for needle deployment. As a precaution, do not deploy the needle until the handpiece is properly placed. The proper placement of the needles and selecting accurate needle length are essential. It is important to note that improper positioning of the handpiece, misplacement of the needles, or utilizing improper needle lengths could result in patient harm. To fully deploy the needles and retract the shields, firmly pull back the trigger mechanism until the trigger reaches the automatic stop. The needles and shields deploy together. The shields retract slightly to prevent tenting. An audible snap will be heard and a click may be felt, which means the needles and shields have been properly deployed. Confirm the handpiece is flush against the urethra wall. Start the radiofrequency power delivery by pressing and releasing the orange on-off switch on the handpiece cable. The switch functions only as a press and release switch and is not designed to be held in the press-down position. Confirm that the lesion in progress appears and is monitoring output on the screen display. The lesion time is automatically set for 2 minutes and 20 seconds. Carefully monitor the urethral temperature during the lesion. Start to irrigate at 40 degrees. Immediately irrigate the urethra if it reaches 43 degrees Celsius. If it does reach 43 degrees Celsius, a warning tone will be heard and a message will appear. If the temperature reaches 47 degrees Celsius, the radiofrequency energy automatically shuts off. To keep the urethra cool, irrigate with small flushes of irrigation fluid. Use approximately 0.5 to 1.0 milliliters of fluid. To drain the bladder, open the stop cock to the aspiration position. When the lesion treatment is complete, confirm the lesion complete message appears on the screen display and fully retract the handpiece trigger mechanism. Move the trigger mechanism forward until it moves into the fully retracted position. This completely retracts the needles and the shields. Confirm the trigger mechanism is up and the needle retraction shows solid white and no blue. Continue through the lesions and treatment planes until treatment is complete. When the treatment is complete, the physician must make a decision on catheterization. Some physicians choose to place a Foley catheter. The catheter is generally in place for 48 to 72 hours following the treatment, but occasionally may be needed for up to 5 days. Other physicians may prefer to conduct a voiding trial to determine if a catheter is necessary. Finally, physicians may instruct their patients on self-intermittent catheterization. Following treatment, the patient may experience several days of abdominal discomfort and irritative voiding symptoms. Unless they are contraindicated, it is suggested that the patient receive a short course of oral nonsteroidal anti-inflammatory and an antibiotic, as well as 2 weeks of alpha blockers. Prior to releasing the patient, it is important to explain what to expect for the first few days following the treatment. Post-procedure instruction should include what is considered normal and what requires medical intervention. It is also a good practice to remind patients that they should begin to notice improvement within 8 to 10 weeks of the treatment. Overall, the patient should be able to return to normal activities within a few days. The Prostiva RF therapy procedure provides safe, effective, and durable relief from the symptoms of benign prostate hyperplasia. Patients have proven to show significant symptom score and flow rate improvement sustained out to 5 years, and 86% of all patients remain free from surgical retreatment. For more information about using Prostiva RF therapy and the support available from Urologix, please view the Urologix support module.